Hello, everyone. Thank you for joining us for today's webinar on the Hope for Contraceptive Security project in Malawi. Good morning, good afternoon, good evening. My name is Meg Schmidt, and I'm a program associate with EngenderHealth. I'm joined by my colleague Siti Kachingwe, our project manager in Lilongwe, as well as project director Jane Wickstrom. And EngenderHealth is really pleased to co-host this webinar with the Reproductive Health Supplies Coalition, or the RHSC. And our colleague Sophia from the coalition has a sentence or two of background. Sophia?
Yeah, great. Thanks so much. So I'll just give a little context for those of you who aren't familiar with the coalition. The Reproductive Health Supplies Coalition is a membership organization with 364 partners committed to increasing access to a full range of affordable, quality reproductive health supplies in low and middle income countries. And this project was issued through our Innovation Fund, which is our flagship initiative for high impact change. It serves as the coalition's small grants mechanism for financing innovative ideas to increase access to reproductive health supplies. And the project was carried out through one of the coalition's implementing mechanisms, the Systems Strengthening Working Group, which aims to strengthen the global, regional, and country systems needed to ensure reliable and predictable reproductive health supplies. So as some of you may know, if you've been working with the coalition or particularly the Systems Strengthening Group, the last mile has been a big focus for the coalition in the past year or so. So we're really excited about this country level work, which really demonstrates how some of these challenges of the last mile can be addressed and ensure contraceptive security for the women who need it. So thank you so much to Jane and Meg, Siti, and the whole EngenderHealth team for all of your great work, and we're so excited to be sharing it with everybody.
Great, thanks Sophia. So as she just explained, this work was indeed implemented with support from the Coalition's Innovation Fund and in close partnership with the Ministry of Malawi. And in recent years, the Ministry has made remarkable improvements in contraceptive prevalence and strengthening systems at the national level to improve contraceptive security. However, there are still contraceptive security challenges at the district and lower level health facilities. And as Sophia just mentioned, this work has really focused on the last mile or last kilometer to improve contraceptive security. So we have a lot to share today, and we want to leave plenty of time for discussion, but we'll save questions and answers for after the presentation. And if during the webinar you happen to have any technical issues with sound or you're unable to see our screen or the presentation, please note it in the chat window of the webinar, and Sophia will be monitoring it and will help to resolve any issues. So with that, let's get started. So here's an outline of today's discussion. Our project director, Jane Wickstrom, will be sharing background on the COPE for CS methodology, as well as an overview of project implementation. I will be presenting on items 2 through 6 on the screen, including results from baseline end-line facility assessments, service statistics, ideas from key informants and stakeholders, and some information on the way forward and next steps. And then we'll open up for group discussion, during which Siti Kachingwe and Lilongwe will help us address your questions. We've been having some network and connectivity issues in Malawi, so we appreciate you bearing with us on that, and we hope it will all go smoothly.
Great, thanks so much, and welcome everyone. We're very excited about this project and the results from Malawi. First, I really wanted to take a step back and have a definition for us to work with today. At EngenderHealth, we've expanded the definition of contraceptive security to the one that you see on the screen. Contraceptive security exists when people choose, obtain, and use the contraceptive methods and services they want in order to meet their reproductive intentions throughout their lives. And I think we really want to focus not on the actual stuff, the contraceptives, but also that service piece. So for an individual facility to have full contraceptive security, we believe there are 3 basic elements that must be there. Of course, the contraceptives themselves, the medical equipment, instruments, and expendable supplies for those methods, especially the long-acting, reversible, and permanent methods, and a trained provider. Because if you don't have those 3 elements, you really will not have services and you really will not have contraceptive security. So what is COPE? COPE, I hope most folks have at least heard about COPE, but it stands for Client-Oriented Provider-Efficient Services. You see, with that dichotomy, we really are looking to address clients' rights to health services and provider needs to offer those services from the ministry level to the community level. COPE is a performance improvement and problem-solving approach with tools. And COPE for contraceptive security, we're going to say CS today. COPE for CS is the newest COPE tool, and I'll tell you a little bit about how it was born. But we have many other tool books for a range of health issues, including reproductive health, several in the HIV care and treatment area, male circumcision, cervical cancer, abortion care. Those are just a few of them, and you can find all of those tool books online. But the whole idea of COPE is really about problem solving, performance improvement. I'm going to take a few moments and look through the COPE logic model. I think it would help really set the stage of what we're doing today. So you see on the left-hand side the COPE activities. So staff are engaged through a facilitator that they pick for themselves. They are engaged in defining service quality. COPE participants identify and set priorities for their particular quality of care issues. Again, this is really just at the facility, last mile location. COPE participants identify root causes, make an action plan, and organize a COPE committee to follow up the process. And I think that's really important to show that everyone is involved, everyone has a role in improvement. And most importantly, I think, the process of identification of problems and problem solving, that continues over time. We actually recommend these meetings of the full staff quarterly, or we've often seen it's very helpful in regular staff meetings to just pull out the COPE plan and see where things are moving. The outputs, which is the orange box to the right, are outputs from those activities. And we've seen these types of outputs in many locations over time. The quality of service delivery is pretty much universally identified as a priority. The capacity of staff is built to really problem solve, and if they can't get the job done by themselves, they can ask supervisors and districts for assistance. But something we hear over and over again is that teamwork, staff morale, and motivation are increased with this process. Next, we look at the outcomes box, that after working through issues, facilities often meet basic service standards that had not been met before. Progress is made with quality of care, such as cleanliness, better client flow, improved infection prevention practices, and today we'll be looking at those improvements with the lens of contraceptive security. A great outcome that we've seen and documented is that clients are satisfied with services received after they see these improvements. The impact, easy to go through. It's increased use of health services. When you have high quality services and clients are getting their needs met, you have an increased use and overall improved health status and health outcomes. So that's the model. I want to take a brief moment to look at the tools that we have developed for COPE for contraceptive security. That right there is the COPE assessment guide that you're seeing, a lovely woman in her now highly organized storeroom. Within the guide, there are 10 technical self-assessment guide issues related to contraceptive security. I'm going to just rattle them off quickly. They are organization, staffing, and facilities. That's one. Organization for logistics management systems. So that's really focused on, are there tools, are the supervisors involved. Logistics management information systems are in working order and used. Then we get down really into the logistics technical areas of procurement and requisition, inventory control, warehousing and storage, transportation, distribution, financing and budgeting, and then the planning cycle, which is also important. And lastly, we have a checklist, self-assessment guide for medical instruments, equipment, and expendable supplies. The next aid is a job aid, and this is a laminated 2-page front-back that was developed in Tanzania with the most important questions that a supervisor would need to ask in each of those 10 subject matter areas. So these are used to spur discussion and to work with the team in a very easy way with this job aid. So I'm going to give you a very quick history of COPE for Contraceptive Security, and again, it was born in Tanzania, and it was the newest COPE tool design. We started in 2011, and we all recognize that there are issues with stockouts at facility levels in many resource poor settings around the world, and so we worked with our colleagues at the Ministry of Health and Social Welfare to really design this tool to look at things like improved FIFO adherence, looking at how facilities are storing their drugs and helping them with forecasting, reporting, and such. So this tool was developed and in fact used over several years, and in the Ministry of Health has now taken the COPE for CS as part of their toolbox for quality monitoring and supervision. So I could go on and on about Tanzania. We have some fabulous results. If you're interested, you could go on our website. There are technical briefs showing the great successes in Tanzania, but we're going to focus today on Malawi. We were working in Malawi. EngenderHealth was there on other business, and they heard about what had happened in Tanzania in terms of improvements in not only the contraceptive logistics management, contraceptive security, but also in pretty significant increases in of family planning. So they said, wow, can we do a replication of that here in Malawi? And we said we would love to do that. So under EngenderHealth's Respond project, we tested the COPE for CS tool to address stockout issues in facilities in Malawi. And then later on, of course, we had the fortunate backing of the scale up for contraceptive COPE for CS under the Innovation Fund. We worked in 2 districts in Malawi, in Salima and Mengochi, and that was really the basis for our learning under the Respond project. After we finished that pilot, the ministry said that they would like to scale up the approach and selected 60 sites and had, again, 18 from the initial facilities under the Respond project and then 42 scale-up facilities with support from the Innovation Fund. We did training of trainers on the methodologies in 10 districts. We then cascaded that training and approach throughout. And I think what's really important to realize is that we had a focus on monitoring and evaluation, because as a scale-up endeavor, we really want to document the process and show our results for further learning. So there were baseline end lines done. Service statistics were monitored and analyzed via the DHIS2. We monitored the facility action plans in all of the 60 sites, and we conducted key informant interviews. So at this point, I'm going to hand it over to Meg, who's going to tell you all about the results of this work. Thank you very much.
Great. Thanks, Jane. So we'll get started with the results now. And to start off, here is a snapshot of the supported facilities, all of which, as Jane mentioned, were selected by the Ministry of Health and the Directorate of Reproductive Health, along with district health officers of the 10 districts. As Jane mentioned earlier, the COPE for CS methodology was implemented at 18 initial facilities in the Ngochi and Salima districts, and the scale-up phase included 42 additional facilities in a total of 10 districts. The districts were spread across 3 regions of Malawi. This means a total of 60 health facilities have implemented the approach, and you can see here that there is a variety in the level of facility, though most are health centers. And there was 1 CHAM hospital. CHAM stands for the Christian Health Association of Malawi. The facilities ranged in total staff size from 14 to more than 850, though 2/3 of them had 50 or fewer staff, and those with more than 100 staff were all hospitals of some sort. 49 of the 60 facilities were located in rural areas, and the remaining 11 were urban facilities. The data I will present today are primarily from facility assessments conducted at the supported facilities. And for the initial facilities, we have 3 time points of data. They received orientation on the methodology shortly after the 2014 baseline during the Respond project. For the scale-up facilities, we have 2 time points of data. A baseline for these sites was conducted in March and April of 2015, and they received an orientation on the methodology mostly in June to July 2015, leaving approximately 6 months of implementation prior to the end line in January of 2016. This time frame was tied to the short award period of about 1 year, which is typical of Innovation Fund awards. I would also note that the initial 18 facilities did receive refresher orientation on the approach in June to July 2015. The facility assessment tool included questions regarding staff trained in various skills related to Logistics Management Information System, or LMIS, as well as quantification and stock management, trained FP providers, storage practices, stock levels of contraceptive methods and related supplies, and more. And we'll discuss some of these now. End-line data from all 60 facilities showed that all facilities had formed and indeed maintained a COPE for CS committee and developed a COPE for CS action plan. Nearly all, or 59 out of 60, of these facilities displayed their action plan in a place visible by all staff. This is really important for accountability in completing action plan items. For different action plans, there is an assigned staff member responsible, and by displaying this publicly, it really does help to shine light on what's being complete and what remains to be done. 65% of facilities discuss their action plan in a group setting each month, such as during routine staff meetings. Others did so, for the most part, either every other month or quarterly. 37% updated their action plan within the last month prior to the end line, either to note completed items or to add additional action items that they've since recognized as areas to be addressed. Another 30% had done so within the past 2 to 3 months. And further, 8 facilities have actually used the methodology to improve quality in other issue areas, including environmental sanitation and ART clinics. Now, one weakness in contraceptive security is when facilities do not have a trained logistics officer or other staff member responsible for management and procurement of contraceptives and related supplies. On this slide, we see that at the initial facilities, shown on the left, although more than 70% had a trained person in place in 2014, this decreased to 28% in 2015 and then increased back up to 61% at the end line. This highlights a key challenge often noted by facilities, attrition and frequent staff turnover. However, despite the dip at the midpoint, it's encouraging to see this increase for the end line. And at the scale-up facilities, the percentage having a trained person in place doubled from 36% to 71%, Now, as Jane mentioned, COPE4CS is a continuous quality improvement process. And by revisiting the assessment guides or revisiting their action plans, facility teams are able to recognize and act upon issues that arise over time. And hopefully we'll continue these improvements at facilities. Logistics management also requires attention to data and maintenance of good record keeping. The assessment tool therefore asks whether there are trained staff in a variety of related skills. For example, as shown here on this slide, we found an increase in staff trained in completing and submitting LMIS reports. This increased over time from 78% to a full 100% of initial facilities, and from 86 to 98% among scale-up facilities. There were also increases in the number of staff trained in determining what to order and in what quantities, trained in maintaining proper stock levels, and determining quarterly needs, among other skills. We also saw improvements in the stock levels of LMIS and record forms, requisition forms, and issue vouchers, though we will not present further on that data today because of time. The assessment tool asks about the presence of providers trained in different FP methods. This is an important component of security, as Jane mentioned, as methods cannot truly be available without someone trained to provide them. When completing action plans, facility teams often noted a lack of providers in various methods of the challenge, and critically assessing such needs allows the facility teams to advocate or lobby higher up the chain to fill these gaps. We saw positive findings from the 18 initial sites, as shown on this slide, such as general FP and implant providers being posted at most facilities at all 3 time points, and an overall increase in the percentage with a trained IUD provider. We still see a huge gap in the presence of providers trained in permanent methods, and all of the providers trained in permanent methods were from the 3 facilities that were either community or district hospitals. So this is still a large gap to service provision. The picture doesn't look much different here at the scale-up facilities. Again, the percentage with general FP providers as well as implant providers mostly held as relatively high. There was again a noticeable increase in the presence of IUD providers at the scale-up facilities. And these improvements are important to expanding availability of the method, and really lobbying for these additional staff was often included in action plan items. And again, we see that the presence of permanent method providers is fairly low. For female sterilization, of those here, most were again either at the district or the CHAM hospital. So again, these findings highlight one of the challenges we continue to see, and that facility teams still note and around, which are challenges related to staff transfers and turnover. Now, COPE4CS facilities also experienced an increase in supervision visits from district leadership. When asked whether the facility had received a supervision visit in the past 3 months, initial facilities receiving such a visit increased from 61 to 78% between the baseline and end line, and scale-up facilities also increased from 67 to 83%. It's very exciting to see this increased level of support. In general, we've seen great support from district leadership during the project, and you'll hear a bit more about this as well when we share some findings from key informant interviews. We know that important components of providing FP and ensuring contraceptive security relate to infrastructure, and the majority of facility action plans actually highlighted issues related to infrastructure. And we were pleased, as you see here, to see improvements in the percentage of facilities, both initial and scale-up, that have both clean running water and a power source of some kind, whether that be electricity, a generator, fuel, or solar power. There's still some room for improvement here. We also see an increase in the availability of transportation between the facility and district levels, which is really important if there is a need to redistribute some commodities or to fill an urgent gap. The most common type of transit available was an ambulance or public transportation. Now, among initial facilities, 80% transport available in 2014, and there was a slight dip in the midline, but then it rose back up to 89% at the end line. And this is another example of COPE4CS as a continuous process, facilities recognizing the decreased availability of the problem and acting together to correct it. And among scale-up facilities, there was a very large increase of transport availability by 15 percentage points. The assessments also found high proportions of all 60 sites actually adhering to procedures for organizing commodities according to first expired, first out, or FIFO, as well as proper labeling and separating expired or damaged products from their inventory. And these were at 95 to 100% and maintained. The proportion with proper storage room conditions also improved from roughly 90% to 100% from the respective baselines to end line. This included rooms being clean, free of trash, with sturdy shelves and organized boxes. And the photo on the right, we actually see an improved storage room at Salima District Hospital with the family planning commodities very neatly labeled and organized, and they were following FIFO as well. The proportion of facilities with the storage room in proper condition, which is important to protect commodities from sunlight and water penetration, also increased from less than 90% to close to 100. Now, we did still see some areas for improvement, including having sufficient storage space for existing products and storing products at the appropriate temperature, and we hope with additional time implementing the methodology, we'd hope to see some improvements there as well. Now, as we've mentioned, the COPRA-CS methodology is not only about reducing stockouts of contraceptives themselves, it's also about ensuring that consumables and expendable supplies related to the provision of quality family planning are available. The assessments therefore also checked whether a long list of supplies and materials were in stock. Some of them, for example, included those focused on infection prevention, or IP, and the amount of facilities with a functioning sterilizer, an autoclave, or a steam cooker increased among initial facilities and was maintained at about 75% among scale-up facilities. The proportion with essential IP expendable supplies, defined here as a safety box as well as either chlorine, bleach, detergents, or some other disinfectant, also increased among initial and was maintained at 90% in scale-up facilities. You'll hear later today that we're working on a journal article with some of these findings, as well as a final brief, and those products will include more results related to the various supplies, but again, for the sake of time today, we'll be moving on. See point-in-time measurements showing the proportion of facilities with each contraceptive method in stock anywhere at the facility on the day of each assessment. So this is not just about being in stock at the pharmacy, it's being in stock anywhere at site. Among the 18 initial facilities shown here, although situations in short-acting methods, we see improvement in the availability of injectables and long-acting reversible contraceptives, or LARCs, such as implants and IUDs. Moving on now to the 42 scale-up facilities, we see similar fluctuation for condom supply, but we also see less drastic changes in the availability of LARCs between data time points. And this may be related to the short time frame for implementation under the Innovation Fund award. It'll be interesting to see if these facilities have more noticeable changes, just like the initial sites, after additional time implementing the methodology. While we were just looking at point-in-time stock information by method, I want to discuss now a situation we all know too well, which is facilities placing last-minute emergency orders for contraceptives. And we're really happy to share that the need and placement of these orders is decreasing among the COPRA-CS facilities. On this slide, we see the proportion of initial facilities placing emergency orders in the past 3 months, reporting either no orders placed in pink, one or more orders placed in purple, or reporting that they were unsure if any emergency orders had been placed, shown in orange. A don't know response may indicate that either no one available on the day of the assessment was able to answer this particular question, or that in fact the facility's record keeping was so poor that they were unable to answer based on their own records. Among the initial facilities, the baseline on the left showed that at least 50% had placed an emergency order in the past 3 months, again that piece of the pie in purple, and 39% weren't sure, so it's likely that some of that 39% had also placed emergency orders. However, we see at the end line in 2016, shown on the right, that the number reporting an emergency order in the past 3 months decreased to 39%. There's, of course, room for improvement still, but this is really exciting progress. We again move on to the 42 scale-up facilities. We see a similar trend, with, again, the sites placing emergency orders decreasing. At the baseline on the left, at least 39% had placed an emergency order in the past 3 months, with 21% not sure. So of those, some of them likely also did. Whereas at the end line on the right, this dropped to 30% reporting they had placed such an order. And again, potentially a few more from those who are not sure. So again, this is really exciting progress. Actually, at a system strengthening working group meeting a few weeks ago, Ellen Thompson, formerly of the coalition, mentioned, I know talking about emergency orders is not a very sexy topic, but it really is. It really is a good finding and pretty important. Decreasing emergency orders can really suggest greater awareness and ownership of ordering processes and management of stock at the facility level. Now we will just very briefly discuss FP service statistics. With data from the Malawian DHIS2, we see a trend of increase in new FP users at the initial facilities in Mangochi and Salima over time, from January 2013 to December 2015. We hypothesize that the improved stock on hand, as well as additional trained providers, may explain some of the trend in more new FP users. And for the journal article we're developing, we'll be taking a deeper look at the service statistics from all supported facilities, as well as exploring other contextual factors that would affect this data. So we'll be exploring, for example, that dip you see in the last quarter shown on this slide. It's a bit early to tell what is happening at some of the scale-up facilities, especially as the implementation of COPE for CS began only in June 2015, or for a few sites that had delays slightly later. But we'll be monitoring and reporting back on that as we prepare these final dissemination products, as well as keeping relationships open in the future to hopefully take another look after more time of implementation. All right, so now we'll be moving on to the key informant interviews, which were conducted with stakeholders at facility, district, and national levels in June 2015, as well as January 2016. And a total of 19 informants were interviewed. And here we see some of the key ideas. So multiple informants noted that the provides a framework for identifying problems that can either be solved internally or that may be solved with outside help. So even when there are challenges stemming from issues beyond the facility's control, with the action plan, the facility can identify and map out those issues for which advocacy to higher levels or to other technical assistance partners may result in the desired outcome. Informants also noted improved communication with district staff who were aware and oriented to the methodology, and you'll hear a little bit more about that as we move on. And informants also noted a sense of ownership for the quality of their work. A district nursing officer in Mangochi noted that because the methodology is facility-centered, it imbues senses of ownership and recognition. And she said that the key is really that it's not just the management who are involved. You have people doing work from all parts of the facility. And that dovetails nicely with some other key informant quotes we have that share that teamwork and communication within the facility improved. One informant at EngenderHealth Center in Nzimba South District noted that his staff were responsible when he introduced COPE to CS for them. And although, quote, there is still shortage of staff, but cooperation and relationship have improved. The workflow is heavy, but now the workflow is lighter since there is teamwork. Similarly, an informant from Kendeu Health Center in Nincheu said it was easy to identify problems. However, there was a lot of discussion before coming up with a solution. This taught us to respect one another's ideas. And that same informant also noted that everyone at the facility is involved. Really, the exercises at the facility level and the COPE committee bring representatives from each department at the facility. So they're all aware of the methodology and the issues and can appreciate the challenges their teammates face. Informants also noted that facilities are engaging more with their communities. Here we see Frederick Kapinga from Monkey Bay Community Hospital, and he noted that after going through the action plan and discussing together as a team, they recognize that they actually have health advisory committees that include political leaders and other partners, and that those partners and members of the committees should be contributing to some of their infrastructure, but the facility wasn't really communicating their needs with them and wasn't giving them support. So they had things in place, but didn't know they had them or how best to use them, and after going through the methodology, made changes. So we'll quickly talk about a few next steps in the way forward. The project actually held a dissemination meeting in Lilongwe in early March, during which we shared details of implementation as well as some of these results. And there were more than 70 people in attendance, including, we were very honored to have the minister shown here on the right, as well as the Secretary of Health and the Director of Reproductive Health, who all attended and gave remarks supporting the importance of contraceptive security, access to family planning, and support for the use of COPE for CS goals. And further, at the meeting, we also had the district health officers, district nursing officers, and family planning coordinators of all 10 districts, and representatives of traditional leaders in attendance. There were also other civil society and development partners, as well as USAID and in attendance. During that meeting, some of the useful feedback we received from stakeholders included the recommendation that the methodology be scaled up to additional districts. There's currently 10 out of 29 districts. Stakeholders also suggested that other partners providing technical assistance should be involved in the scale-up, given the different geographic scope and reach of various partners. It was also recommended that in the future, we allow for a longer implementation period and consider using control groups or facilities to better document the results. These are certainly valid suggestions that would help strengthen the evidence. Under the short period typical of this award mechanism, just a year for the project, it was difficult to do this, but we're certainly keeping these recommendations in mind for future work elsewhere. So what's next in Malawi? As from the beginning, the methodology is really facility-owned and a continuous process. Although the project is closed, the 60 facilities are continuing to implement the methodology on their own. EngenderHealth is in the process of developing a journal article, as I mentioned, which will include deeper analysis of some of the results of all of the results I presented here, as well as additional results. And we'll also explore predictors of success in completing action plan items, such as frequency of discussion of the action plan or characteristics of the facility. The full results are being shared with all 60 facilities so they can review as they continue implementing. And we'll continue to disseminate the results and lessons to aid in scale-up. In future dissemination, we'll also be reporting on some of the RHSC suite of stockout indicators, which are a really great resource, and we encourage other partners to use them. Because of when that suite was released late in 2015, we're not able to report on all of them from both baseline and line, but did tweak our N-line tool to add some additional questions. So our future dissemination will include more of that information as well. And the Ministry of Health has also expressed interest in scaling up further. The funding for that is to be determined, but in the interim, EngenderHealth will make technical assistance available to other districts and partners interested. On Malawi, so COPE for CS is actually slated to be implemented in additional countries, including Uganda in 6 facilities under the Expand SP project, as well as in a total of 58 facilities in 4 countries within the EngenderHealth family planning program in West Africa. There also may be some interest in using it in India and the Philippines down the road. And lessons from the Malawi scale-up work are informing plans for these countries. And of course, evidence and process documentation from these future countries will also add to a global body of multi-country experience. And with that, we'd like to thank both everyone for joining the webinar today, as well as the Ministry of Health and especially their Directorate of Reproductive Health for their really close collaboration and partnership. They were involved in training of trainers and trainings and every step of the way, and it would not have been possible without their dedication. It also would not have been possible without leadership of all the districts, as well as the actual staff at the facilities. It's, of course, a facility-owned methodology, and it's thanks to them that progress is being made, and thanks to their communities for being engaged. We'd also like to express gratitude for other partners supporting service delivery and logistics management, as well as the Family Planning Association of Malawi, provided some administrative support for the project and our but efficient team. And of course, we'd like to thank USAID for funding the introduction of the methodology via the Respond project and their continued input, RHSC and the Innovation Fund for supporting the current work. And you can, please, I've just listed one email here for the sake of screen space, but please shoot me an email if you'd like more information. There's also info online as well. And now, just before going to questions, we'd like to make one quick plug for the Take Stock campaign by the Coalition. The campaign recognizes that reproductive health supplies have broad repercussions, both for the women and families seeking access services, for the providers who wish to offer quality services, and beyond. And EngenderHealth as an organization has signed on to this campaign last year, along with nearly 50 other implementing partners, donors, coalitions, partnerships, and country governments. So anyone seeking to learn more about that campaign may visit the website listed here, or can reach out to the coalition or to EngenderHealth. So now we'd be happy to answer any questions that you have in the time that remains. As I've mentioned, Siti Kachingwe, our co-PRCS based in Lilongwe, will take the lead on answering questions, and in providing those answers may share some of her perspective and experience as well. And I think it'd be easiest if you can answer questions within, if you can submit your questions within the chat window of the webinar. I know that there have already been some questions submitted. Sophia is letting me know of that. The presenters have not yet seen the questions. So while we, along with the coalition, to find the questions already submitted, please feel free to continue submitting other questions.
Meg, I can read some of the questions that have come in. This is Sophia.
That would be great.
Okay, so Erin Larson-Cooper said it appears that the scale-up districts consistently had a higher baseline than the initial districts, and what do you attribute this to?
Siti, did you hear that?
Oh, let me unmute Siti.
Unmute, yeah.
Just 1 second. Okay, Siti.
What was the question again?
I'll read the question again. It appears that the scale-up districts consistently had a higher baseline than the initial districts, and what do you attribute to this?
Okay, in the initial districts we had 18 facilities, and in the next districts we had 42 facilities, a total of 6. Now, when we were doing at the second time in 60 facilities, based on what Meg has presented, you'll note that the facilities that had the earlier baseline have improved more than the facilities that are doing that were being implemented for the first time. So that's what I can add. Maybe Jane can add.
Yeah, it's interesting to note that the DRH of the Ministry of Health selected the sites, and I think we should maybe go back to them and see, wondering if they actually selected sites that they thought were performing better overall and wanted to get them to a much higher level. But it's an excellent question that I think we could go back to the ministry because, again, we did not do site selection.
And while going back to them, I think it's also important to this question now, and we've done some thinking on it, but we'll certainly explore that for the journal article and brief that we'll be releasing at the same time.
Yeah, it's a great question.
Okay, so I hope that answered your question. I'll read the next question, which was, if you could elaborate more how the LMIS system was utilized to facilitate improved ordering and timely delivery.
The availability of contraceptives in the country depends on what the logistic officers at the facility level. So when the facilities send their statistics, they send them to using the LIMS to the Department of the LMIS, and from there that's where those statistics are sent to central medical stores. So central medical stores sends the contraceptives. If we don't have a trained logistics officer at the facility level, then it will implicate it has implications with the LMIs, because they don't know what to write, they don't know what are needed. But in facilities where you have a trained person in logistics, and they can make good requisitions on the contraceptives, the improvement is better. So LMI is better, the system is better in a facility where we have somebody who is trained in logistics, and therefore they do come with good statistics.
Okay, thanks, Siti.
Was that clear?
I'm assuming that was clear. No follow-up chat has occurred. So the next question is, are there tools to measure ownership or sustainability?
Are there what?
Are there tools to measure ownership or sustainability?
Yes. Okay. Sustainability was already built in when the project was starting on. The first thing that we did, and EngenderHealth did, was to discuss with the ministry. The ministry actually chose the facilities. They did identify the facilities, and they identified the facilities where there were problems with contraceptive security and with supply chain. That's one. Already it's ownership, because it's the ministry that is identifying the facilities. When EngenderHealth was starting the project, all district health officers, district nursing officers, and district family planning coordinators were invited to a meeting where it was described to them. At this meeting, the ministry chose districts. The district health officers, nursing officers, and family planning coordinators chose the facilities. So each district identified their own facilities. And as EngenderHealth, after this meeting, we did a TOT. And after the TOT, we had the cascade trainings. And all those people were being identified by the district health office. And it is the district health office that was actually doing the trainings. What EngenderHealth was doing was monitoring and supervising. Now that when EngenderHealth was pulling out from the facilities, already there are people that were already doing the work without EngenderHealth. Supervision was combined with the district management teams. So even without EngenderHealth, the district management teams were going to the districts to find out how COPE is doing. And in Maggie's presentation, she mentioned about action plans. Each facility had an action plan, and those action plans were posted on the walls of the facilities. And those action plans, the DHOs, district health officers, have a copy of all the action plans in their districts. And they, again, were supporting the facilities. So the sustainability was already built in that way. So capacity building and ownership by the ministry was already part of the project from the initial.
Yeah, and I'd just like to add, Siti, that at the dissemination meeting, we heard from the minister, from the Secretary of Health, and the Director of DRH saying that this is what they would like to support in the future for every facility in Malawi, and calling on donors and partners to support it. So in the world of international development, this is about as sustainable, I think, as you can get. It's very exciting.
Yes.
Okay, next question.
Meg, did you want to jump in, or I can just read the next question?
Yeah, actually, that would be great because on my questions tab, I only see old ones. I don't see any new that have come
Okay.
in.
So the next one is, are you working in all districts or some health facilities? I'm not totally clear. And then there's kind of a follow-up, which maybe is a separate question, which are, what are the challenges, the biggest challenges you face during implementation? So you can take those one at a time if you prefer.
We are working in 10 districts and in 60 facilities. So that's where we are working. Challenges, yes, we had some challenges. The first one was staff, what would we call, staff movement. You know, you trained this and then there are transfers, staff have gone to school. That affected training, the project in some facilities. And then even management transfers of the management teams at the district level also affected the project. That's the major challenge. But all in all, we had we ended up with more contraceptives in the facility, in most facilities, despite the challenges that we had.
Okay. Sissy, the next question that came in is, how involved were the local leaders in this CS model and what role did they play?
Okay. When we started, you remember I said that we started with discussions with the Ministry of Health. The Ministry of Health identified the districts. The district management teams identified the facilities. When we went to the facilities, meetings were held with the traditional leaders in the catchment area of each facility so that they also were getting concerned that because of the non-availability of contraceptives in their facilities. And in each village, there is a village health committee, and there is a health advisory committees, which are available in every community. So all the action plans that were developed in all the facilities were sent to the health advisory committees, and the chairpersons of all health advisory committees are traditional leaders of those catchment areas in each facility. So when action plans were written, traditional leaders saw them and they discussed with them. In certain facilities, we have activities that were identified that by on the action plans, and they were managed, they were implemented by the communities. For example, in places where they didn't have water supply in the facility, the health advisory committees, which are headed by the traditional leaders, took those matters up through the councillors and then through their member of parliament, who supported those facilities to have water supply. That's just one example. So that's how the traditional leaders worked. And in some facilities where they wanted, maybe they had smaller drugstores, the communities molded bricks through the advisory health committees when they saw that on the action plan. So the traditional leaders led those communities to come up with bricks, sand, and then the facilities continued extending the drugstores. So traditional leaders were really very important and supported the project a lot.
Great, thanks, Siti. And the next question is, how were you able to involve the Central National Medical Stores during the project life?
Within the ministry, there are several committees. One of them is Contraceptive Security Committee, where we discuss about supply chain and the availability of contraceptives in the facilities. EngenderHealth was a member of this team. Central Medical Stores, this committee. Central Medical Stores is a member of this committee. So because contraceptives are sent to the facilities direct from the Central Medical Stores, when we meet in these meetings, EngenderHealth was able to tell them to communicate within the committee based on the supervisory and monitoring supervisions with the district management. What's really happening at the last mile? Are contraceptives that the central medical store is sending adequate or not adequate? In the process, we found out that there were issues in relation to requisition of the contraceptives. The medical stores was only sending what the facility is asking for, but the facility were not asking adequately. However, we were liaising with the central medical stores through these committees, and the central medical stores through JSI have had supervision visits as well. And once in a while, we have met at a facility while they are looking at availability of contraceptives in those facilities. So when we meet in these meetings, we're able to discuss. That's the relationship with central medical stores. And in these meetings, the Ministry of Health and specifically the Reproductive Health Department attends these meetings. So all stakeholders in relation to supply chain and contraceptive security, we do meet quarterly to discuss issues like that, and that includes central medical stores.
Great, thanks, Siti. And I think it's also important to note, as we mentioned earlier, that the Directorate of Reproductive Health really was a partner throughout almost all of the project activities and was really heavily involved. And within that included Roy Makeka, who's responsible for reproductive health logistics in the country. He was part of our training of trainers and cascade training and really involved with the implementation and design. So it was also great to have that DRH support in addition to the committee meetings, to have multiple ways of communicating and collaborative with CMS. So it's 11 o'clock now, so we recognize that many people will need to move on. Do you want to take another question? Okay, so we have one or two questions in the queue, so we will those one or two more questions that have already been submitted. And if you need to depart, we thank you for joining us. And now we'll move on to one or two last questions. So Siti, the next question is, does COPE have tools that track the results like what you have mentioned, or the tracking tools were innovatively developed by the in-country EngenderHealth team?
So,
yeah, that's okay. I can, and thanks everyone again for bearing with us. As we've mentioned, we've had connectivity issues with Malawi, so thanks for bearing with the repeats. The question was about whether COPE has tools to track the type of results that we presented today, or if the tracking tools were developed by the EngenderHealth country team.
Can I help you?
Yes, yes.
Yeah, I was going to say that the COPE action plan is in it of itself a tracking tool, because you're adding, the group's thought about what would be an issue to address, who needs to address it, when it will be done, and actually puts in when is it completed. So the COPE action plan is a tracking tool. And then the staff in Malawi would then collate all of that through the 60 sites. So there is some collation that needs to be done, taking the results of the COPE action plans to a higher level, yes.
And then the results that and the data, the quantitative data we presented in the slides today were from baseline end-line facility assessments, which is a separate tool, but the data is all shared back with the facilities as well. They are the real owners of the data. And so while that, our monitoring tool developed for the project and to measure the scale up and the data, EngenderHealth can also share that type of information in that tool as well.
And then the final tool is really the use of the DHIS2 for the service statistics.
So it's a combination of approaches to monitor progress. All right, we have one more question in queue that we'll address before we sign off today. And Siti, the next question is, were there any internal or external facilitators that have been moved from the district during the implementation, and what was the solution to keep the process continuing in the face of that challenge?
We foresaw that initially when we were starting. So, for example, at district level, at national level, everybody was involved at the district, at the reproductive health. So it's the director, the focal person for family planning, the logistics officer, the youth officer, all principals responsible for reproductive health issues at the DRH were all involved. So they were all trained and conversant with the project. And then at district level, all DHOs, nursing officers and family planning coordinators. And we trained 3 trainers, COP4CS trainers at each district. So when the DHO, for example, moves, then we have the district nursing officer taking over. And then at facility level, we had the site facilitator. And the site facilitator, the first thing that they were doing after training was to train the facilitator. But as a leader, as a site facilitator, when he leaves within the facility, they were having problems to identify another leader. And it was involving the district to help them choose another leader to take off. So that was delaying. But the facility had adequate staff to proceed with CORE.
Excellent, Siti. Thank you so much for the insights from the field. It really helped this discussion very, very much.
Thank you. Thank you.
Okay, now with that, it's 11 a.m. in New York, later elsewhere, earlier elsewhere, depending which direction you are. So we're going to sign off this webinar today. Thank you everyone so much for joining this discussion. I think we really appreciated your questions and of course to share some of these exciting results. And as we've mentioned, we're working on a journal article and there will be future dissemination as well. So stay tuned for more. And I've moved back to this thank you slide so you can again see one last time my email address. It's mschmidt@engenderhealth.org. Please feel free to send any additional questions our way. So thanks so much, and big thank you to the Reproductive Health Supplies Coalition for funding this scale-up work, as well as for co-hosting this webinar, and to Sophia for all of her support with the logistics.